the, the the obesity epidemic as well, but it surfaces. It's funded by the industry.
And yeah, I just want to reiterate what Jeanette said, and I think the tobacco industry is a prime example of interventions that don't work, but they have the money and the wherewithal and the political clout to move them. So a prime example domestically is the We Card program, which you've probably seen in convenience stores. That's a tobacco industry initiated effort, but it's what you see plastered over every convenience store in the country. And so a lot of times it's a matter of certain interventions which are not effective are just being rapidly disseminated because there's more dollars or the entity that's behind it. And in most cases, it's the tobacco industry domestically.
Last word, did you have another question? No?
No, I guess I understand all that and I appreciate it. I agree with you, but I also think there are things that haven't been funded by the tobacco industry that have spread. I spent years working in a state health department as a cancer epidemiologist, and I know we did a lot of things that weren't effective just because we thought they were the right, because there was buzz around them. Even aside from the evilness of the industry, I think there are lots of lessons we can learn about things spreading and scaling without the right evidence. Yeah, and I agree completely. And I think also that you have to give leeway to building the evidence base. And so a lot of times when you're building an evidence base, you're going to make mistakes. And so that's happened a great deal. But fortunately now we do have resources like, the 2012 Surgeon General's report was very clear about school-based interventions and outright didn't say that they were all that effective. But people still continue to implement them alone when the Surgeon General's report was very clear that they have to be in combination with other efforts. So a lot of times the evidence is there, but people aren't adhering to it.
I'm going to come over here. I know. I'm going to flip-flop. Thank you, though.
Thanks, sir. Terry Allen from the Cuyahoga County Health Department in Cleveland and from National Association of County and City Health Officials. Thank you for your presentation. Brian, you can send all your egg-based Christmas cookie questions to local health departments. We'll take care of those for you. An editorial comment quickly, and that's the insidiousness of little cigars and higher rates among smoking among minority populations and flavored little cigars. And maybe you'd say a word about that. That's a personal pet peeve. But I actually have a question about Sally, something you said earlier in the day about affordable housing and braided funding and banks and supporting and incentivizing that process. And maybe your sense of where that's at and the scalability of an intervention like that would be interesting to hear about. Thank you.
I'll touch on it because that's a personal pet peeve of mine too. So the flavored little cigar issue, for people who don't know, tobacco products and cigars are taxed based on weight. And so if it weighs a certain amount, it's classified as a cigar. So in 2009, the Family Smoking Prevention and Tobacco Control Act effectively banned characterizing flavors in cigarettes. So what the tobacco industry did to circumvent this was they added weight to the products. They used kitty litter to increase the weight of the product so it's the same size, shape, weight, and filter as a cigarette. But since it's heavier, it's not classified as a cigarette. So they circumvented the law, and then they can add flavors because the law does not prevent flavored cigars. So essentially you have a cigarette in disguise that has circumvented the law and can be sold in flavors. And what's more horrifying is that the use rates are highest among minority populations, specifically non-Hispanic blacks. And so it's just a prime example of the industry morphing over time to adapt and identify loopholes in law so they're not quite as effective as we initially anticipated.
And my comment, I liked the term that was used earlier, virtual braided funding, to think about how health from the national level and other programs from the national level might cooperate together. And HUD has been, for some years now, recommending but not requiring that multi-unit housing, multifamily housing go smoke-free. And it's moving along in a positive direction in North Carolina because there is another situation where the public health interests overlap beautifully with the business interests. And we have an attorney on our team who we brought in with the community transformation grant money that took this to another level and started working with all of the affordable housing managers who are private business people who take some funding from HUD to see if we could put an incentive process in the qualified application process for receiving HUD monies. And when we first started this, they sort of said, no way, no how, but then as we've taken all of these properties smoke-free, and it's been good for business and good for public health, and the collaboration has been so strong between us and affordable housing and a lesser degree public housing, but they're moving along in that direction. We, with our partners, put in a note to the qualified application process this year that specified the specifics of why this was a good idea to give the tax credits to opening smoke-free. I attended the public hearing last month. It was amazing for me to be in a room full of businessmen and bankers who were standing up at the microphone and saying, we want this. And so I think it's going to pass. It will become official in January. The North Carolina Housing Finance Agency will release its final rule on this. And because Maine was the first state to do this, they came and talked to us and talked about their coalition and inspired us. I think we've taken it a step further than Maine because we've got a lot more specifics in the language, and it could become a good model for other states to use. So it's one of those things that once it passes and is official, I'm very happy to get out through this committee.
And I'll just say, I mean, I think this ties back to some of the earlier workshops that we've had as a roundtable around the investment that community development is making in thinking about healthy communities, healthy housing, healthy businesses. The return on investment, Cheryl, you just mentioned it a moment ago, that it's very expensive to sort of clean those units, worry about lawsuits, worry about complaints. It's much easier to not allow it. So
one more note on that
that I forgot
to mention. If you want to read more about where we are nationally about this, HUD has just released a new action guide called Changes in the Air, and it's on their website. So that's getting more into telling the story about the action that's happening across the country.
George?
Just a note to say that Julian Castro, who was the mayor of San Antonio, okay, we engaged him. So it was the Latino community that engaged him into signing a smoke-free San Antonio, even though there were lots of community people against it, and now he is our Secretary of HUD. So investing in policymaking in Latino communities at the local level will eventually have an impact as elected officials and appointed officials are there. I couldn't stop by letting you know that that has happened.
Thanks, Jeanette. George?
Yeah, George Isham, Health Partners, Minnesota, and co-chair of the roundtable. What a terrific, terrific panel. And, you know, reflecting my own involvement with tobacco over the years, I could get into the discussion of tobacco. But you're here to give us lessons about the larger topic of spread and scale, both positive and negative, about creating a larger climate of health, including tobacco control. So given that, I hear the necessity for granular metrics at the community level, which is an issue of not which metric is the best to use, but the system of complete information at a granular enough level for engagement, which I think is an important takeaway. Secondly, I see the regional disparities in 2014 of policy implementation in terms of smoke-free workplaces mirroring the mortality kind of maps in the country. And I hear the billions in funding the 18-to-1 ratio of a well-characterized and designated and entrenched enemy. And I worry about the long-term success of that. So for me, that raises the question, which we had come up in our workshop on movements. We had a workshop on movements where a number of movements have to have a clear enemy to mobilize and so on, based on this. Raises the question of the wisdom of the overall strategy of creating an enemy as opposed to co-opting the resistance. And I think we should, as we think about the broader topic of a community of health, we need to think about whether we want a nation where there are have states and have not states and division along political lines of the tools and policies necessary to create broader health in the country. So this panel, more than any, has really raised that question with a wisdom of the strategy of characterization of this as an enemy. New media, the youth, and communications, the emphasis there on the importance of that, and then disparities. Disparities, you know, our definition we started off the day with, it's, you know, the distribution of health within the population as part of the definition. And if we aren't having reach, this is now becoming less of an issue of science, less of an issue of intellectual endeavor, and more of an issue of engagement of individuals, where they lie culturally, where they lie from a standpoint of education and so forth, which is a skill set that I suspect that industries are much farther ahead than many of the public health advocates. So that's something to ponder in terms of overall strategy. I am impressed with North Carolina and what you have achieved, given the barriers. There are many lessons there for how we should move forward. So thank you for those comments. I really appreciate any comment you would have back to me in terms of this enemy issue.
Having been in the belly of the beast on that one and I have to unfortunately leave because I'm late for a meeting at Times Square that is, I'm already going to be quite late for. Though I gave a pessimistic opening about the ability to scale up and sustain an effort that is anti-industry, especially if you have to go out and raise the money to do it and get the corporate partners to come along with you. I did not mean to in any way suggest that there isn't a critically important role for telling truth to power. And I think there's a hugely important role. So that in this, others may not agree with me, I do not think without a national media buy sustained for the Truth Campaign, there would have been a public education strategy coming out of the CDC or the FDA. I think that one of the reasons that happened is they actually saw it work. They weren't going to do the same thing, but they saw it work. The evidence was being written about by the IOM, by NCI, by various places. And then the other side of it is I do think that you have to give the industry a wake-up call. You have to draw the line in the sand somewhere. I think we're exactly at that place with the gun industry right now and the food industry. And I think that we're getting tiny movements from the food industry that are in very long time frames that will take a very long time to have a substantive impact. And we have a regulatory environment, I'm sure I'm preaching to the choir for everybody in this room, we have a regulatory environment that's such that it's going to be very hard to deal with it centrally. Michelle was talking about state preemption. Let's not forget federal preemption.
Right.
This whole swath of areas where you can't do anything about it in the state because it's been preempted on the federal level, which is where the greatest amount of corporate dollars are spent to get the policies that they need centrally, and then less so at the state and less so at the city. So I do think you need your, call it lunatic fringe, trendsetters, draw the line in the sanders, which I don't think precludes all those other efforts that you're describing because they're critical too.
Thanks. Sani, and then we'll come over to you for the last question, and we're going to wrap it up.
So first, as a native North Carolinian, I want to give a shout out to Sally for all you've done to make North Carolina a healthier place, which maybe someday I'll be coming back to. So thank you. So my comment kind of follows George's in a way. I worked with Mark Manley, who was at NCI, and then came to Minnesota to head up Blue Cross's Center for Prevention. And so we were talking about the leading causes of illness and death, so tobacco, physical inactivity, poor nutrition, and alcohol. And so I said, so Mark, we're working on tobacco. I said, so when are we going to take on the others, and what does that look like? And Mark said, well, you have to think about how many multi-billion international corporations you're going to take on at a time. And I was like, oh, that's a pretty wise thought. But given that, what do you think, because there's no level of tobacco that's safe, but then you got, food and alcohol, and you can't say that there's no level, et cetera. So what do you think does apply from what you're learning in tobacco that you would say, as we think about spreading and scaling many interventions related to health, so we would be going after some of the others, what would you say to us? A wisdom that you've gained from working on tobacco that you think does apply to the others when you're dealing with multi-billion-dollar international corporations?
I'll start from the community level, and these are mostly my observations from working with my colleagues, but thanks for the shout out about Dr. Manley, who was our leader with Project Assist. And in some ways, what I've told my colleagues working on obesity issues is that I wish that they had a Project Assist. It was a brave commitment of resource dollars at a time for tobacco control that was really needed. And I think in some ways, what we've all been saying is that you shouldn't be investing in things that you don't know work without serious evaluation resources attached. And that's what Commit and Assist did for tobacco control. And many other funders continue to do that. We're continuing to advance the evidence. I think there are some lessons that I'm seeing in community levels. Remember the innovative hospital administrator who first pointed out that hospitals should go tobacco-free. He also learned a lesson from tobacco control where he priced the hamburgers high and the greasy foods high in his hospitals and the salads low. So he took a lesson from tobacco control from price that you can change what people purchase and eat by changing the price of the products. We're also looking at food deserts and places where healthy food is less accessible. Trying to get SNAP approved in our farmers markets, and our farmers markets more accessible to everybody in North Carolina. So we're looking at ways that we can take advantage of our local food movement and appreciate the farmers that we have in our communities and put real food in the hands of real people, not just manufactured food. So those are some of the things we're working on in North Carolina here.
And I think that one of the things that was done right in the tobacco control movement was that we had something called the Advocacy Institute. And it brought together leaders of multi-sectoral, if you will, representatives in cohorts of 10, 15. And what happened is that the underpinnings of what we called partnership building were built there. So in order to scale up, you need these cohorts that represent national leadership, because then you can learn what's happening in California, because some of our cohorts were from California, or in Texas could learn from what was happening in Minnesota, as well as from minority communities. So that it needs to be not only thought of as a scalable leadership process, but as an investment for partnership for the future.
And I would say, Sonny, one of the lessons that I think we're learning across not just tobacco control, but childhood obesity, housing, is that return on investment and doing the work that's necessary there and finding those stories of success to hold up, where you have the innovative hospital executive or you have the restaurateur who wants to sort of say, I'm okay with this and I'm going to serve healthy foods, I'm going to have a smoke-free environment, or you have the folks who are willing to invest in new types of development practices and really holding them up and doing the work to sort of capture the return that they're getting, the benefit to their bottom line, the benefit to the goal that they're seeking to achieve, and also the benefit to community health. And to the population's health. And I think that's something that is a transferable lesson around spread that allows us to then pull in even more partners as we talked about in our lesson, our exercise earlier, is how do you co-create so that people really feel like they have an accountability and an ownership of it. All right, last question to you, Martha, and then we're going to wrap it up because I know Debbie wants to get to the next speaker.
Okay, I think this is short. This is Martha Gold from City College and member of the Roundtable. We have heard in the Roundtable in previous meetings about resources, funding, and obviously we're well aware that the tobacco funding to counter tobacco use is lower than it needs to be. We've heard a lot about social impact bonds, and I wondered whether in tobacco, where there's so much evidence of effectiveness of programs, whether there has been work with people who are interested in social impact bonds, maybe in accountable care communities. Has there been any kind of work in that area that any of you are familiar with?
No, not that I'm aware of.
So, no, not specifically for tobacco control, but there is more work being done around asthma. And I think it's been focused on sort of lead abatement, environmental exacerbators that are tied to then emergency use room, healthcare usage. And so there are investors who are starting to look at that and becoming more and more interested in it. So I don't think it's too far off in the future.
Right, because, you know, the possibilities, if one were to look long-term and to get investors to think long-term for cardiovascular disease, for pulmonary disease, would be fabulous. And I wonder whether that's something that the Roundtable can sort of think a little bit more about. Thank you for great presentations.
Well, please join me in thanking the panel.
Thank you. That was great. I'm going to take a cue from Michelle. Everyone stand up, stretch, because we have one more speaker and then our closing, which Jacqueline and others are going to lead. Let me ask our speaker to come up as well. I think I just saw Joe somewhere. Oh, great. Oh, good. Good, good. So I can't think of a better person to close, to do our keynote closing than Joe McCannon. He is really, I think, one of our country's experts on spread, scale, and sustainability. And I was just so thrilled when I heard, you know, that he could make this and really be our closer. So thank you very much, Joe. And you have Joe's wonderful bio in the packet. Joe is the co-founder of the Billions Institute, a nonprofit that has helped successful local initiatives expand broadly and rapidly. He's also a consultant to the Bill and Melinda Gates Foundation. So please help me welcome Joe. So we'll have a half an hour of his keynote and then about 30 minutes for questions. So please think of your questions.
Well, thanks very much. That's a very nice introduction, very generous, and thank you all for having me here today. I've really enjoyed the conversation. I've picked up a lot of insights that I think will be very useful, and so it's been a great day already. I think what I'm going to do here now, and what my charge is for the next half an hour, is to think somewhat explicitly about what a population health large-scale change initiative might look like, what expanding impact in population health might look like. And the way I'm going to do that is really to kind of take a comparative approach and look at some examples of initiatives and programs and so forth that have been successful and try to extrude some lessons and some concepts that will be relevant to us in framing this work. I'll look back a little bit on what we've discussed already today, try to distill it a bit, and I'll mainly look forward to what this group might think about as it contemplates the future of expansion in population health. So kind of a tall order, but I'm willing to give it a shot. And I would say that before I begin, you know, this kind of exercise sort of rests on an assumption, by which I mean there are kind of prerequisites for even having a conversation like this about going to scale. And the prerequisites are that we do in the space or area in question have some promising prototypes, have some promising evidence base that we can lean on. And I think we've heard over the course of the day today, and we certainly find in the literature, examples of successful prototypes and pilots that would increase our confidence about the ability to have an impact in population health at scale. We also need attention from influential leaders and stakeholders. Many of them are here in the room today, but I certainly think at a national level and a local level, a lot of people are thinking about population health in very explicit ways that are encouraging. And we need to have a conducive context. And what I mean by this is kind of, it's what Bill Keller in a really interesting column last year called Obamacare, the rest of the story. It's kind of the confluence of payment and experimentation and a legislative environment and a regulatory environment that's very, very conducive to change. And that's what I think we have here right now, this special moment that Obamacare has stimulated in some way, and that many of you have really reinforced on the local level. And I think, looking beyond government, if you are one who thinks that the market is really the bellwether of where energy is, I think there's no question that if you look at venture capital investment patterns, if you look at what banks are doing, if you look at where universities are investing, there's really a significant or at least a notable increase here. This is a graph I came upon this summer about digital health funding. This is from Rock Health and was actually on CNBC. I think that's where I first saw it. The digital health funding in 2014 has broken previous records. It had exceeded the total for 2013 by this summer. So, we really are seeing significant energy and attention in this area. So I'm going to start on the premise that we do have a conducive environment. We do have a moment that is appropriate to be thinking about expansion and scale in the way that we're discussing. And so you might view that as kind of speculative, but I'm going to still go for it in any case. And I would also just say as an aside to the earlier question, which I thought was very interesting about whether we have a sufficient evidence base in scaling and spread. I agree with the statement that it is an incomplete field and an incomplete science, but it is also a very pedigreed science with a lot of history, and there's a lot to draw on there as well. Going back to the work of Granovetter and Rogers and well before that, kind of this nexus of sociology and communications and operations research, network science, there really is a lot to draw on here. So I think we can be relatively confident that we have enough to go on to actually begin, and we'll continue to learn and refine the science as we go. So that's my starting point. So with all those caveats, the question I want to answer over the balance of the time here is how do we really seize the moment in population health? Where do we go from here? And I'm going to answer the question, as I said, by looking at some case examples from different sectors. And these are sectors that I've worked in and sectors that I've studied, sectors that I've supported, and really try to use these as analogs that might be relevant to the group here as you sort of think about building this attempt to expand impact in population health across the U.S. And I'll start by just saying that it's not easy, that this type of change is very, very hard. The famous statistic about any change initiative is that it fails 70% of the time. There's another statistic that it says it takes 17 years from the time something is established as evidence-based in the peer-reviewed literature until the time it is actually adopted in a majority of facilities. I'm kind of dubious about both of those statistics for reasons that I could explain, but nevertheless, the point is change is really, really hard. And I think this quotation from Doris Lessing captures it so well. I think when people look back at our time, they will be amazed at one thing more than any other. It is this, that we do know more about ourselves now than people did in the past, but that very little of this knowledge has been put into effect. I mean, this is kind of this is a definition of what injustice is in some ways, and it is kind of at the heart of a lot of the work that I think many of us do, but I think it's important to be explicit about it in the way that that she is. So the question I want to ask all of you, just as we launch into this discussion and to try to bring a bit more life back into the room, the question is, why is it so hard? Based on everything that you've heard here today, based on your own experience, why is it so difficult for us to take what is sound, what has worked locally, to a larger scale? And if you wouldn't mind, just find someone near you, just take 30 seconds and just quickly come up with one or two ideas about why this is so difficult. What are you taking home from the day-to-day in terms of the most notable barriers? Okay, I'm going to bring you back to the group. Time is a real tyrant here right now. So let me just ask, would a few brave volunteers just be willing to shout out what they view as the big reason? What's your reason why we struggle so hard to make change and change at scale? Why don't we spread things effectively?
We know intuitively what is the right thing to do, but it is not, has nothing to do with it.
Interesting. Okay, so there's a disparity between evidence and our kind of intrinsic knowledge. Okay, okay. Others? Yes?
We apply complicated thinking to complex problems, try to engineer the solutions rather than emerge with collective wisdom of people.
I am going to steal that sentence. I think that's right on the nose. Other barriers? A lot of people vested in the status quo. One or two more others. Sustainable resource streams. Yep. Any more? Okay. Well, you know, you've hit on a lot of them, but this is kind of my subset or short list of challenges that I think are really, really meaningful when we talk about going to scale. The first thing is there is a very crowded marketplace of ideas. Look at your email inbox when you leave this meeting. Look at the requests that you will have to do many things that are very important to the people who are requesting that you'll do them. We're just simply inundated with things that we could do to make the world a better place. So that the sheer volume of information and the sheer volume of ideas is a barrier. There's what I call the myth of natural diffusion. The idea that if we put something out there in the literature, or we put something out there to the world, that based on its merit, based on its intrinsic value, people will see that it makes sense and they'll take it home. And there's really very little evidence at all for that. There are conflicting values, and I think this is something that we sometimes underestimate. When I was working in Southern Africa in the early 2000s, and we were trying to expand voluntary counseling and testing, and we were trying to reduce or expand access to antiretrovirals, there was a whole other movement that was going on in parallel to ours, which was about abstinence. It was a very different movement with a very different set of values. And I'm not here to disparage it. That wasn't the movement I was a part of, but those movements are out there and they do exist. There's inertia. Someone mentioned inertia, business as usual. I mean, I just share with you, I am right now in the process of supporting what are to me two very important large-scale change initiatives. And since the Wednesday before Thanksgiving, I have not at any time reviewed data or given a thought to the tactical things that we need to do to have more success in those initiatives. Why? Because I've had 3 reports to submit, I've had several talks to prepare, I had 2 afternoons of conference calls, I had an inbox full of emails, I had a family crisis to tend to. I mean, it's not that people are bad and sitting on their hands, it's just the force of our daily lives is an immense force to contend with. There's resignation and apathy that you've all described. There's competition. You know, I worked in one field which I will not name, and it took me about 6 months to figure out that the 2 leaders of the 2 most prominent organizations in the field that were trying to solve a very important problem in a state simply didn't like each other, and they didn't want to collaborate, and they wanted to win. They wanted their organization to win. This isn't surprising. This is what human beings do, but it undermines change, and it undermines coming together to do things that are bigger than what we might do as an individual organization. And then there's fear, and fear is the enemy of all change. Fear as a desire for control, fear as a fear of trying new things, fear of others getting recognition. All of these things really undermine change. So at some level, when you look at this list, you think to yourself, my gosh, it's a wonder that we could ever do anything at all. It's a wonder that we could ever change anything, especially change things at scale. But what I want to talk to you about are those exceptional initiatives, the initiatives that, of the 50 or 60 that I'm drawing from here, really do something that's remarkable, that actually just feel very, very different. When you walk in the door, if you were to walk into the door to the 100,000 Homes campaign as an example, it's breathtaking. If you were to walk into Rashad's work when he was working in Russia, it would almost make you uncomfortable because they're moving so fast and they're taking in data and making adjustments so quickly. It's just a different experience. So what I'm going to do is I'm going to tell you about typical initiatives, or what is kind of commonly done, not with bad intentions, but just kind of as a result of that inertia, and then talk about exceptional initiatives, the initiatives that really stand out and what their behaviors are, and hopefully that will leave you with a list or a set of ideas that might be relevant as we contemplate this expansion of population health. So the first thing we see, I think, in a typical initiative is what I call comprehensive strategy development, and it goes directly to the comment that you made about sort of developing complicated strategy for complex problems. It's a natural tendency when we're looking at complex problems to say, we need to take time. This is so messy. We've really got to think about this from every possible direction and consider every eventuality and just permute to try to solve this problem. Instead, what you see in the initiatives that I think are successful is a bias towards starting. And it's a bias towards starting not despite complexity, but because of complexity. And this is kind of a very flip summary of a paper that I really like from the Aspen Institute, about a 120-page paper, so it takes a little time, but by Auspice and others. And it basically says complexity actually means that excessive strategy is wasteful and even possibly absurd. Because engaging with the world under such a complex environment is the only way we're actually going to know what works. We can't, it's just impossible to predict it. We can do a little modeling. There's some network mapping that I think is interesting that gives us a little bit of a clue. But until we actually engage with the environment, we aren't going to understand what we need to do. So that's the rationale for beginning. Complexity means there's no silver bullet solution, and so we have to get started somewhere. That, I think, is one characteristic you'll find in initiatives that really succeed. Another characteristic of typical initiatives is an emphasis on consensus. We need to make sure that we get all stakeholders to the table, around the same table, to agree with one another so that we can make sure we're moving in lockstep with one another. It's the spirit of cooperation. And again, nothing nefarious about this, nothing sort of intellectually that doesn't make sense, but in reality, because consensus is a very complex process, we find that the initiatives that succeed sort of take on this view that consensus actually kills, that if we have consensus about aim, if we have agreement on what we're trying to accomplish, that the process of trying to get to a perfect consensus, particularly on smaller decisions, is actually damaging and is not something that we can actually tolerate if we're going to make change at the rate that we need to make it. And I don't say this phrase consensus kills to be hyperbolic. It does kill spirit, but it actually, I think it also, if we take too long, can have an impact on human suffering and in some cases on human lives. General goals for expansion, we heard this earlier today from Rashad. General goals for expansion, vague goals for expansion are a characteristic of initiatives that don't succeed. That, we are going to make population health better in the United States isn't particularly helpful versus explicit time-bound aims and really being concrete about what it is that we want to try to accomplish. Some is not a number, soon is not a time was kind of the tagline of the 100,000 Lives campaign at IHI, and I think it's a good little mnemonic. We want to know how much we're going to accomplish by date certain. And we decide that by understanding what full scale looks like. So what would full impact look like? We really need to understand that in quantifiable terms. But not just to always say that we're going to go to full scale in one move. That's unrealistic. That doesn't really seem to work. But we actually kind of honor this rule of 5x to 10x. And this comes from Tom Nolan and others, API and the Institute for Healthcare Improvement. This is the idea that for any phase of expansion, when we move from prototype to pilot to scale, that a rate of expansion of 5 to 10x is about right. So if we were, when we started the 100,000 homes campaign, we were in about 20 cities. And when we went to our expansion phase, our target was 200 cities. And that was sort of a stretch goal. But 2,000 cities, we couldn't have done it. The wheels would have come off. So there is kind of a natural rate of expansion. This is not a hard and fast rule, but it does come from industry. And I think it's one that I've found has held us in very good stead. The Millennium Development Goals, I think, are an interesting example to point to. Not without controversy, but interesting. These 8 goals to be achieved by 2015, which I think where we've seen pretty remarkable progress globally, particularly in certain regions of the world. Maybe there are community development goals. Maybe there are 7 or 8 things we can do in communities around the U.S. which focus action and give us a time-limited sense of what we actually need to accomplish. I'm sure within this room we would have some good initial ideas about what those might be. A fourth thing is that we see in initiatives that tend to struggle when it comes to scaling is they design for success. And what I mean here is that there's sort of intensive, resource-heavy investment in making sure that we have a success at all costs. And unfortunately, that doesn't account for the fact that when we expand, we have to do what the first speaker talked about today, which is manage our marginal costs. We actually have to reduce our marginal costs and introduce economies of scale over time. So a better model is designing for success and for scale from the outset. And here, I think, the thinking of Everett Rogers and others is very useful. Just when we're looking at the idea or the intervention that we're designing, let's be rigorous. There's actually a scorecard in the improvement guide that you can use to say, have we established a relative advantage? Is the relative advantage clear on a scale of 1 to 5? Is this something that is significantly better than what came before? Is it simple and straightforward? When we launched the 100,000 Lives campaign at IHI, our national patient safety campaign to avoid unnecessary deaths in U.S. hospitals, our methicillin-resistant Staph aureus guide, the guide that we developed in its first draft, was 143 pages long. How could you imagine someone in a unit taking that and doing anything with it? So we reduced it to about 12 pages. Those are the things you need to do when you're thinking about scale. Compatibility refers to compatibility with people's values and their beliefs. Can we make sure that we're doing things that at least overlap enough with people's beliefs for them to feel comfortable in taking them on? And then trialability and observability. This says that if we're going to ask someone to do something different, which requires some real activation energy, they should be able to test it and feel it and experience it and see its benefit in a matter not of months or years, but days or even hours. And the best at this that I've seen are salespeople. My brother-in-law used to sell packaging machinery. I can't think of a less sexy thing in the world to sell than packaging machinery. But he could, in the course of an hour, show you all the bells and whistles on the packaging machines and then present you your product in a recyclable package. That gives someone a visceral feeling for what we're trying to accomplish. And then we've got to think about, I think maybe I skipped a slide there, maybe I didn't. Then we've got to think about audience and audience segmentation. What you saw earlier with Rogers' diffusion curve, we've got to think about not only adoption categories and who is likeliest to be our innovator and where our laggards are in our population, but we've got to think about other segmentations too, by geography, by readiness, by profession. We really have to be masters of the population of the people we're trying to reach. For those of you who are quality improvement people, it's obsession with customer. It's the same principle. It's obsession with customer, but just at a broader level. And then there are these infrastructure requirements, and this is actually a modification of a slide that I got from Marie Schall and IHI. If we are going to go to scale, if we are going to create these economies of scale, we have to think about all of these things. Human resource requirements, do those scale? Financial resources, physical space, equipment and supplies, data collection, technology, logistics, oversight. All of these things are critical to think about in the early design phase. And the sooner we account for them and the sooner we think about them as we imagine going to full scale, the better off we'll be. This is where the broad knowledge of the audience is. The next thing is what I was referencing earlier, which is in a typical initiative, there's broad knowledge of an audience. In an exceptional initiative, there's this detailed audience segmentation. And as I said, you know, there's the classic Rogers breakdown that says for any innovation, a given population will break down in the following bell-shaped curve. But there are these other possible segmentations that I think are very, very relevant that I mentioned before, and we really need to think about those as well. In a typical initiative, I think there just tends to be a default to one stimulant, to one incentive for driving people to change. And when I was in the government, our primary focus, Darshak talked about this earlier, was payment. I mean, that's what we believed. And there were a few people who called themselves incentivistas. If we get the incentives right, the world will change. I don't think anybody believes that. I know Darshak doesn't believe that. But that's something that can happen and become problematic if it becomes a default way of thinking. By contrast, exceptional initiatives use a lot of different stimulants to drive change. And here's a list of stimulants that you can imagine. Some are positive, some are negative. I'm of the mind that the positive stimulants are better to use most of the time. There's kind of an 80-20 rule for this, but sometimes negative stimulants, things like regulation or punishment, are appropriate where there are cases of negligence or people who are maybe intentionally sabotaging the process. But I think that we have to just be creative about thinking about all of these stimulants. You heard Linda's story earlier about Ed Givens, and I'm not going to repeat it, but you know, the first time I heard that story, what had been for me a kind of technical interest in how do we expand impact on homelessness became very, very personal. And when I saw Ed Givens in a three-piece suit at the White House this summer celebrating the success of the 100,000 Homes campaign, you know, I was in tears. You know, I mean, that's the energy that you get when you rely on more than one incentive, and when you think about these other meaningful connections and sources of energy that people bring to the work. Another, I think, pitfall that's typical is relying too much on one teaching method or relying too much on didactics in general, assuming that if we could just get to people and tell them what we know, that things will change. When in fact, I think many learning methods is more appropriate. Weaker hypotheses when it comes to spread are papers, pamphlets, courses, websites, conferences. These aren't bad things in and of themselves. There's a place for them. But if we're really talking about spreading change, and if we look at a budget and these things are 30, 40, 50, 60% of the budget that we're looking at, for me, that's a real orange flag or a red flag in some cases. Instead, we want to look at some of these methods that Rashad described earlier, methods which essentially democratize the change process. And that, for me, is a critical concept when we think about scaling and when we think about spread. What we're doing is we're saying everybody out in the field, everybody out in the world has to stop feeling passive. They have to start feeling empowered, as if they are being given charge of taking science and taking ideas and making them work in their own environment or their own circumstance. And each of these methods, I think, tends to that in really interesting and different ways. I'll tell you that this is a very small list. Gene Sharp has, you know, a list of 198 methods for stimulating social action. So this is just the tip of the iceberg. There's a lot here that I think we can draw on that will give us energy. But the core principles of any learning method that works are that they have hands-on application, they require people to test things themselves, and there's a high tempo or a rhythm to actually trying these new things. And it's happening every day, that people are seeing their results, understanding the data for their population, and making adjustments on a daily basis. The currency of the realm is data over time. I think, again, you know, dashboards are wonderful, but if they just show us point-in-time information, that's not very useful. A run chart or a control chart tells us much more about trends and shifts and things that might be happening in the field. So those are things that you look for. We talked earlier about the point about replication versus adaptation, and I'm not going to overmake the point. All I'm going to say is that I visited Sweden, and I visited a great group in Sweden in Jönköping County. Jönköping County is an exceptional performer when it comes to healthcare and public health. In fact, in some areas, they perform an order of magnitude better than the rest of Sweden. And Sweden is, like, you know, on the pedestal for being one of the best health systems in the world. And I said to one of the leaders of their innovation center there, I said, what's the secret? What's the key? You know, what do you guys do well that makes you exceptional? And he said, we're jazz players. We're improvisers. You know, we know the theme, we know where we're going, we know generally where we need to get by when, and we also suffer from no angst about surprises. So if the data tell us that we're off track, if we have difficulty from a political leader, if there's a bad story in the media, if we lose 3 staff, if our funding source gets cut off, that's just all in a day's work. It's not a reason to stop, it's just a reason to adjust and make a change. And that is kind of the attitude and the spirit I think you see in these initiatives that really thrive. It's true not just at a local level, it's true at the level of a movement or a large-scale change initiative too. When you think of the patient safety movement, something that I've been a part of at times and very interested in over the last decade, you know, I actually did a timeline that went back to the turn of the prior century, to 1900. You know, you see this movement from sort of improving medical curricula to the creation of the CDC, to the Joint Commission and accreditation and standards, to some landmark reports like the Institute of Medicine's To Err is Human report, increased media attention and public attention. Suddenly there are some interesting prototypes in a few health systems around the country. There are campaigns like the 100,000 Lives campaign. State departments of health get drawn in. You know, the essence of this is, improvisation is not the right word here, but opportunism maybe is more appropriate. The idea that we're opportunistic about what the world gives us, and as a movement, we're very quick to jump on the opportunities that are presented. All right, this next point is one where I always get myself into trouble, and so I want to make sure I talk about this in a kind of deliberate way. In a typical initiative, often a heavily funded initiative, there's concern about summative evaluation for several reasons. Sometimes it's to do with attribution, often to do with the fact that the donor or the foundation or the government who's ever given the money is worried about establishing the value of their investment and understanding what happens so that they can make better decisions in the future. And that's appropriate. So I'm not here to disparage summative evaluation, but what I would tell you is that it's a complement to formative evaluation. And for me, starting with formative evaluation as the priority is a hallmark of a large-scale change initiative that's going to succeed. And what I mean by that is that there are all different types of learning that are appropriate for all different types of challenges. And I think that formative evaluation, if we're talking about scaling, is a prerequisite to be able to understand what's going on. And if there's worry about contamination or worry about adaptation, it basically it ties our hands behind our back. The essential thing, this democratization of change, this allowance for local adaptation and appreciation of local context is eliminated by a summative design that's too restrictive. So I think they can coexist. I know they can coexist. I've seen them coexist beautifully, but I think that formative evaluation is a critical piece. This is the dashboard from the 100,000 Homes campaign from Philadelphia, and you see that monthly housing rate that Linda referenced. I mean, I think that is galvanizing. It's what everybody understands and looks to, and it is, again, it doesn't exclude other forms of evaluation or other forms of learning, I should say, but I think it's critical to have it there. This is in a very remote part of Honduras, in Copan. These are run charts that I saw on the wall there, and you know, unsurprisingly, this was a region and a district that was having much more success at improvement because they had not just data, but timely data that they could use to make adjustments on a weekly basis. So this, again, is I think, critical. A last point here, and then I'm going to wrap up. In a typical initiative, I think, one that struggles to get to scale and have impact at scale, I think the system is one where management sort of sits on high and gives approval. Where there's a reporting structure where those who are taking part in the work are trying to make sure that they don't upset a person higher up on the chain. In the initiatives that really work, management has as its primary job barrier removal. And this is some work we did in Central America in my work with the Gates Foundation to sort of draw a comparison between the typical scenario, what we were seeing in most countries, and the alternate scenario, which is the one that correlated most highly with better results. In the first scenario, district representatives submitted reports to the central office. The central office rewarded timely submission of data. The central office occasionally reviewed data and ranked performance, and underperformers were called in. And as a byproduct of that, and this will come as no surprise to any of you, a lot of people were tempted to fudge their data. That is a very common byproduct of a system that's set up like that. In the second scenario, senior officials visited districts and facilities on a rotating basis. They spent 25% of their time reviewing progress together on the same side of the table. So it wasn't as if a group was standing in front of leaders and saying, here's our progress, don't worry, everything's okay, and all the bad stuff isn't really as bad as you think it is. They were sitting down together and looking at data and trying to make sense of it. And then they spent the balance of their time identifying specific barriers that leadership would remove by the next visit and identifying new tests that local owners would run. I hope it's apparent to you how different those two things are when it comes to how we manage large-scale change and the impact that those two things will have. What we're really doing, if we're successful at having impact at scale, is we're spreading culture and we're spreading values. And the culture in the first scenario here is one where there's fear and there's limited learning, and the culture in the second scenario is one where we're invested in the outcome and figuring out every day how we get closer to solving the problem, how we do it together as a team. And these things, you know, I have had people say to me at different times, you know, this is kind of soft stuff, you know, and does it really make that much of a difference? And of course it makes all the difference, you know, and my partner, my business partner, Becky Canis Margiotta, and I have this thing we call the John Cusack rule. I don't know how many people here know John Cusack. I was in a college group a few weeks ago, and like less than a fifth of the room knew who John Cusack was. So yeah, I want to ask. It's kind of bizarre. It's terrible, right? Wonderful actor, I thought, from the 80s and 90s. And he was on the show Inside the Actor's Studio with James Lipton, being interviewed about his career. And James Lipton said to him, you know, John, I've noticed you're doing less acting these days, and you seem to be doing more producing. And tell us, like, what is it that's essential about producing? What is the job of a producer? And he thought about it for a second, and he said, you know, I think if I had to boil it down, I think the job of a producer is to keep the set free of fear. And it just hit me between the eyes for some reason. I just thought, you know, that's kind of, if you're leading a large-scale change initiative, that's kind of the essence of the thing. You're keeping the set free of fear so that people are going to test and fail and try and experiment and be transparent about problems and come to you with obstacles as rapidly as possible. So that, I think, is the essence of what we're trying to create. When you bring all these things together, when you look down the right side of the slide here and you think about all of these exceptional characteristics, I think what you create, and this is my last slide, is something called a paradise built in hell. And this is a concept from Rebecca Solnit. And I don't know how many of you read Rebecca Solnit or her books or her essays, but I said to someone yesterday, she could write an essay about my shoes, and I would read it. I mean, it's just, she's a great writer, and she's one of these people who always makes you stop and say, wow, I didn't think of that. That's a different way of looking at it. The essence of this book is that she studied communities that had been involved in disasters, volcanoes, earthquakes, hurricanes, wars, so on and so forth. And what she found is that when people were looking back at their lives, the experiences that they characterized as the most joyful and the most meaningful were actually those experiences. And they used the word joyful, which seems a little bizarre, but I'm sure you've experienced that. I've experienced that. When you lose yourself totally in a cause, when you don't care about who gets credit, when you don't care about anything other than how am I going to put my shoulder to the wheel with other people and get a great result, it's totally liberating. And it creates a container, a space where there's so much energy and so much action that it's addictive. You kind of never want to leave. And that, I think, is the sort of the quick thumbnail version of what you'd be looking for if we think about building a large-scale movement here. It's building that paradise built in hell, a command center where rapid change is happening, where there's limited fear, where there's lots of quick data, where there's lots of quick adjustment, where it's safe to fall down, where we really deeply understand our audience and we constantly get out to the field, where we're constantly making our intervention better. That's I think the essence of a large-scale change initiative that succeeds. So I'm going to stop there. I guess I'll just stop with something like an apology, which is to say, obviously, I come at this with a very specific bias, which is I'm a practitioner. I occasionally publish, occasionally do a conference or something like that, but that's not what I do. So I have a strong set of biases here about what works actually out there in the field. So if I've violated kind of principles of research, or if I haven't been as thorough as I might be, I apologize. But I just want you to know that that's kind of the perspective I'm taking here and where I'm coming from. And appreciate your giving me the time, and look forward to talking more today. Thanks.
Boy, that was great. I really want to thank you for your insights. I particularly love the chart on the exceptional and the typical. That was just terrific. So you were fantastic and just what we needed. So thank you. We only have 15 minutes for questions. Let me just start out with one, and then I know Linda has one, and there are others too. Please come to the mics. Come to the mics. Okay. My question is asking your advice. Earlier, Darshak in the panel, I think it was the first panel of the day, talked about the fact that there's this misalignment between where payers are. I don't really mean, CMMI, because of course you're there, but I mean the private payers. Where the payers are and, where we are with population health. And so we could have great prototypes, to use your language. But if we don't have the payment system aligned, right, to value those, that's a huge barrier to spread. Yeah. So my question to you is to give us your best advice and thinking about how to crack that barrier.
Yeah. Okay. I would say my...
Here, go ahead.
My first response there is I would cite the statistic that Darshak cited earlier, which is that there are now a pretty significant minority of lives are actually sort of covered under value-based models or population-based payment models. 10, 15, 20%. And depending on how you're counting. So I kind of think that that's pretty close to the critical mass that you need. And so my advice would be, and it was what I was thinking when I was a part of CMMI, let's nail these demonstrations, let's show these results, and then I think that will be sufficient for the rest of the private sector to follow. I mean, I guess, and already there are some private payers who are, who I think are very closely following what's happening, and they're doing some small tests of their own with certain populations. In certain states, I think there's some really innovative work going on, certainly at the Medicaid level, but also with private payers. If you look at Eastern Oregon, I think there are some interesting examples there. So I don't know. I guess my feeling is like it's that saying which I used to hate, which is the pace of change is majestic. I think we're really 2 and maybe 2.5 years into testing these new models and introducing these new models, and I think the degree of saturation is pretty good and maybe even appropriate given how much we don't know about what does and doesn't work. So I think the private payers will follow, but maybe I'm being naive about that. I don't know. Linda? Okay.
There we go. Linda Kaufman from Community Solutions. Joe, I grew up on a farm in Virginia, and we had extension agents. They showed us how to trim the trees and shear the sheep. And I'm thinking extension agents, as you talk about them, are not that. So could you talk about what you mean when you say extension agents?
That's exactly what I mean. So it's the extension agent has its origins in the U.S. Department of Agriculture, and the idea of the extension agent model is that you have someone who, in a remote geographic area, travels around itinerantly from site to site, brings ideas, collects problems and challenges, and sort of becomes the connective tissue themselves. You know, and I think that that actually is, extension agents don't just need to exist by themselves. Rashad talked about hybrid approaches. The best collaboratives have extension agents that sort of double the work of the collaborative. So they, you know, you do the standard collaborative webinars, conference calls, people coming together in meetings, submitting data, but then you have an extension agent that actually travels around and sort of adds some, yeah, I mean, you're an extension agent. Exactly, that's you. And yeah, it's the field operation is extension agency. And so it's a really powerful model, and you know, one that I think that public health and community health really are world leaders in. And so there's a lot to build on and a lot to draw on there for sure.
Hello? Yeah. Paul Jelinek with Isaacs Jelinek. You say you always get some pushback on the summative, formative evaluation questions, so here it is.
All right, great.
And it gets to, I think, the question that you raised about the financing, and is the financing there? And it strikes me that there's some very good examples of where doing a very rigorous summative evaluation on the front end of your original model or your prototype can actually pay huge dividends in terms of the subsequent rollout. And that if you can convince, if you have compelling data, especially if it includes cost-benefit or cost-effectiveness data as part of the evaluation, it can really help you on the financing end going forward. So I see it as sort of a sequential process. Once you're into the actual rollout, then a formative evaluation is probably going to make more sense. But to have that rigorous data on the front end, I'm thinking, for example, of the nurse-family partnership, which was very rigorously evaluated with a randomized control trial with good cost-effectiveness data, and it has taken hold you know, across the country.
I think I agree. And I think the only thing I would say is that I sometimes think that when we have conversations, people conflate summative evaluation with RCTs. And there are many interesting and valuable forms of summative evaluation which maybe allow us to appreciate a little bit more of the texture and a little bit more of the context in the way that we do evaluation. So that would be the only caveat I think I would make to what you're saying.
Jean McGuire, Northeastern University. Thank you very much. I was struck by your comment about the critical role of democratizing the process for the change movement. And it struck me that, so you use patient safety when you were talking about that, and during the course of the day we use tobacco here or environmental justice. And in some respects, population health is this big overarching piece that to democratize it, it feels like it needs to resolve to its component parts. Can you speak to that a little bit? Because I think language matters here. It matters what's in terms of population health. It matters in terms of payer and which sector. So would you mind addressing that a little bit?
I think that's right. And you know, when I think this is the first time I've ever used the MDG slide, the Millennium Development Goal slide. That was the rationale there, which is I was thinking about population health, and I was like, what's the aim? I couldn't even begin to know what's the aim for population health, but I could imagine that there are constituent aims where if they were achieved, or if some subset of them were achieved, we might characterize that as population health. So I think it's sort of related in a way to this idea that the only way to start is to start, that I do think we have to identify, you know, by some criteria, something like, you know, the depth of the evidence base, the number of people affected, the, you know, demand, potential funding. We have to identify a cluster of possible practices that we could start with and adopt, and then that might be a place to actually begin and set some of these goals. That's my instinct anyways.
Dave Kindig, University of Wisconsin, thanks so much. And I agree, your chart on exceptionalism is going to become a little blueprint for our work. So, excuse me. I was at an event about a month ago with the IHI Escape Velocity Kickoff, where Don Berwick made a few comments, very few, 10 minutes, but he got in a lot. And he kind of observed I mean, these exceptional components, I think, kind of build what he called a learning system or whatever. You know, I think those were related. But he made the observation at the end that in most of the work that he was aware of, where that was what was effective, there was somebody sort of in charge to manage the learning system. And he observed that because our work is so deeply multi-sectoral, with sort of nobody accountable for whatever the outcome, that was a particular challenge for this field, and he didn't go any further than that. So let me ask you, I mean, do you have any observations about either work you've done or thoughts you've had about how a diffuse accountability multi-sectoral system can still perform in these exceptional ways?
Yeah, my mind is running off in several different directions. I think I would say that I do think there needs to be an entity or an organization that's responsible, or, you know, maybe it's made up of people from multiple organizations, but they're responsible for the learning system. And I think the learning system, it's kind of a vague concept, so I want to try to make it explicit. I think the learning system is, it's a habit of supplying people with data that allows them to do change and improvement themselves, or giving them the ability to collect that data themselves and make change themselves. Having some surveillance function where you study what's happening all around the system and are able to sort of pick out what's good, distill it, repackage it, and redistribute it very, very quickly. And also, it's a system that it doesn't catalog or create databases. It's a system that focuses on tacit knowledge versus explicit knowledge, so that, you know, one of the things I tried to do at the federal government, which just totally crashed and burned, was to say, rather than creating a website for one of our large new initiatives, let's hire 15 people who will be on call for 24 hours who have implemented the practices that we want to implement, and someone can phone them at any time to talk about, how do I deal with this reluctant physician, or how do I manage a resource shortage, all of those kind of nitty-gritty things that actually lead to the change. So I think those are kind of the dimensions of a learning system that works, and I think it's only done intentionally and managed intentionally by a core group of people. That's
Hi, Pamela Russo from the Robert Wood Johnson Foundation. Great presentation. I like biased, empirical talks. I just wanted to give you, there's a very late-breaking statistic. Governor Kitzhaber yesterday in Oregon, since you mentioned Oregon, announced that over their first 2 years, emergency room visits have dropped 20%. I don't know if it's an exceptional thing that's going on there or a typical thing that's going on there, but it's you can go study it and see. And the other thing,
sounds exceptional.
When I read Masood's article about extension agents, it took me back. Do you remember Atul Gawande wrote an article in the New Yorker 2-3 years ago about how the whole sort of rollout of ACA and Medicaid and testing was like the extension agent model, and that's what it sort of needed to turn into.
Yeah, and I thought that was very insightful at the time, and I think we had a real struggle internally when we were trying to introduce new programs within the Innovation Center initially and in other parts of CMS, to say that even if we got the incentives exactly right, that work of kind of one-to-one relationship building and behavior change is still painstaking, important work that requires investment, and that was, we maybe won that battle half the time. You know, if you look at the sort of the nature of the learning systems that are appended to the different programs that were rolled out, and it's just because in some cases that, you know, the feeling was that wasn't particularly value add, or that there wasn't a very deep evidence base for it.
George Isham, Health Partners, Minneapolis, and co-chair of the Roundtable. Thank you for an outstanding discussion. Really appreciate your bias as well.
Thanks.
Very, very useful in many, many ways. And you challenge us a little bit. So you challenge us in terms of, I think, in terms of specific time-bound goals, as opposed to something that's general and vague. And I think you're right there. But I would remind us that in the body of Institute of Medicine consensus studies, we actually have a body of recommendations that in some ways provide us that specificity for some of them, of the goals. So for example, in terms of improving population health, recommendation 1 and the third of the For the Public's Health series, which was published 3 or 4 years ago, funded by Robert Wood Johnson, recommends that the Secretary of HHS set a goal for life expectancy in the country by 2030, and that we set targets for per capita expenditure, with the notion that that would set in process a series of very specific thinking to guide the country in terms of the steps that need to be taken. That sort of leadership is missing in the U.S., and to our shame compared to the international performers. And the specifics are there in terms of getting to that level of specificity. But also, I think your advice is very, very appropriate for this roundtable in terms of us getting more specific and time-bound in terms of what we can do to try to move that forward. So I really, really do appreciate that bit of advice. I think in terms of other aspects of your discussion, it's also important to be very mindful of the fact that, you know, in terms of engagement, we have a long way to go in terms of getting very specific about this, you know, bias toward getting people getting started. I think that's very, very important. But it doesn't, you know, as opposed to mapping out a big, you know, detailed plan. I certainly think there's truth there. But I also think from the last panel that it's very easy to make big, broad mistakes in strategy, and we have a lot of lessons on that from a number of the efforts, maybe the tobacco effort. And I'm not so sure I heard that emphasis in your presentation. So those are a couple comments.
Yeah, again, if I didn't emphasize it, I should have, but I do agree on that wholeheartedly, that I think, yeah, that there can be big miscalculations in developing large strategies, which is why I think there's a real wisdom to starting small. And you know, and that's really, and it addresses that consensus point too, which is anytime someone comes to me and I'm running an initiative and they say, you know, I've got this great idea and I want to do this thing, I always say yes, because I don't want to create a debate about it, but try it with 3 people, or try it, you know, with 1 community or something like that.
It certainly doesn't mean that there isn't debate or careful consideration or about the wisdom of getting started. About what you're doing, about it, making adjustments. But
yeah.
So I think there's a
and to dimensionalize that a little bit, yeah. I mean, you're completely right. I like, you know, when we started the 100,000 Homes campaign, we really took 6 months to get rolling. But, you know, we didn't take 2.5 years, you know. So, I mean, I think there's definitely time for deliberative thought and design, but I think it's probably maybe just setting an arbitrary time frame to say this is when we agree that we'll begin.
So on this goal setting thing, when do we get started? What's the 100,000 homes, the 100,000 lives that relates to life expectancy in this country and equity? When do we get started?
I mean, 6 months from now. I mean, I think you could say, and based on some of the evidence that I've seen in this IHI initiative and what you're referencing that the IOM has done, and what I'm sure exists in the evidence base, I'm sure a set of interventions could be selected and a kind of a loose calculation could be made about possible impact on life expectancy, you know, based on what they've done in Scotland and other countries like that, that would allow a launch 6 months from now, you know. So that doesn't seem beyond the realm of possibility to me. But I think the bigger time investment than actually selecting the aim and even the measurement strategy, and the measurement strategy can always be, I mean, there's a whole other talk to give about measurement strategy, is actually thinking about the operational design and who is actually in that command center, who's in that control room to do the work each and every day, what organizations are represented, and you know, what will be kind of their rules of operation. So to me, that making that investment and figuring that out would actually be probably the biggest piece of work between now and then. So. Thanks.